Hello, everyone. We are so excited to launch our first Back to Basics on natural gut relief. 2025 is going to be an amazing year. And I have a wonderful guest. But before I introduce him, because he's actually going to introduce himself, I want to reintroduce myself to you guys. My name is Dr. Vivian Asamoah. I'm an integrative functional gastroenterologist. I've been in practice for over 10 years. And my passion, my mission is to blend the best of both worlds. So conventional gastroenterology with a more holistic functional medicine root cause approach to provide really the best kind of care to every patient. And our natural gut relief group, Facebook group, has been live for over 3 years. We have 3 to 4 years. We have over 3,000 people, members. And thank you guys so much for following, for inviting your friends. And the whole purpose here is education, right? We want to kind of dispel the myths that we sometimes see on social media. We want to focus on evidence-based or evidence-informed information about what works for the gut. And every Thursday, we present an important topic that you guys have asked about or is really relevant or is cutting edge. And today, like no other, we have an amazing guest, Dr. Elyaman. I'm going to let him introduce himself. He is a fantastic internist and functional medicine physician, but he has a keen interest in something that I think is revolutionary, which is the evolution and treatment of fatty liver and reversal of fatty liver disease. Dr. Elyaman, we're so glad to have you on. Please go ahead and tell us a little bit about you. I know a lot, but you just share what you can.
Dr. V, my pleasure. Thank you for having me on. And thank you for all the inspiring work that you're doing, getting the, you are, I can honestly say you are one of my favorite gastroenterologists. So.
Am I the only one you know? Am I?
No, I know a lot. So my name is Dr. Yousef Elyaman. I'm an internal medicine doctor. I also am a pediatrician. So I did MedPeds residency. I am certified in integrative medicine as well from the American Board of Physician Specialties. And I belong to the first graduating class of the Institute for Functional Medicine that is really kind of looks at getting to the root of disease instead of just throwing Band-Aids on things. You and I both speak for the Institute for Functional Medicine. I speak on the cardiometabolic module, and you speak on the GI, the gut health module. And I also went through the requirements. I need to and took the test and passed and everything to be anti-aging certified through A4M. So that being said, I've been practicing in Ocala, Florida for almost 20 years now. We have a insurance-based primary care practice. We have some things that insurance covers and some things that don't. And we really are focused on primary care, but getting to the root cause. And you had mentioned my interest in fatty liver. What happened, or what I kind of realized the gap was that, like you said, fatty liver is more of a metabolic condition. It's more of and when you send them to a hepatologist, to a conventional hepatologist, they don't know what to do with them. They may give them an experimental drug, but that's pretty much it. It affects 1 in 4 people in the world, and here's the thing, because the liver is the center of metabolism and the center of overall health. Most of the stuff we study in blood is happening from the liver, or the liver plays a role. When that liver is packed with fat or jammed up and not working well, it throws everything off. So what I kind of realized is if I can, first of all, if they had fatty liver, that gave me something to look at, and it was a marker for healing. If I can, and what I realized is if I can get the liver better, I'm going to get their brain better, their kidneys better, and the rest of their body better.
Absolutely. And this is such important work from an internist and primary care perspective, right? Because you're actually working on improving the entire body systems. And this is what I love about functional medicine, Dr. Elyaman. We are moving away from just treating organ specific or disease specific disease, and really connecting the dots and seeing how it affects, working on the liver affects the brain, affects the gut, affects the rest of the body. And this is really important. And I thought it was important to have you on the conversation, like have you in this conversation today, because you are an internal medicine pediatrician, family medicine doctor, right? Who addresses liver disease, fatty liver disease head on. And I want this to be a sounding bell for all physicians out there, primary care doctors, that liver disease is not a hepatology problem yet. When you start and you notice that your patient has elevated liver enzymes or fatty liver seen on imaging, ultrasound or MRI or whatnot, this is something that should ring a bell that there is a metabolic process going on. As an internist, this metabolic process is kind of something you have to deal with. And I want to empower primary care doctors, pediatricians who are also seeing a lot of fatty liver, to learn how to address the root cause and start tackling it from the ground up instead of that quick referral to a specialist. Because just like Dr. Elyaman said, we often don't have the tools or the resources to address this long term. So let's go back to that original question, so we're all on the same, so we all understand what fatty liver disease. If you had to explain this to a 32-year-old, right, young man who is, loves drinking soda, eats out most of the time, and he comes to you and you notice that his liver enzymes are elevated and you say you have fatty liver, how would you explain this to him? He's going to be like, what is this?
So I would probably start by saying, listen, we got the results of your test, and your test is showing that your liver has, let's say, 30% fat, and your liver is supposed to have less than 5% fat. And what that is, what that means, or what that's telling me, is that there is a backup happening. Now, your liver is responsible for your brain health, your heart health, and for the health. It really kind of is the center of your overall health. And what we can do, what we really want to do here, is try to find out why you individually have this fat in your liver. Why is your liver off? And what we want to do is we want to from an individual approach, find out how to start reversing it. And let's get that back to less than 5% the way that it's supposed to be.
Fantastic. Okay, that's great. So this is a great segue, Doc, into asking, well, who is high risk for fatty liver disease, right? This 35-year-old guy is drinking soda, eating quite a lot of processed food. I think from a nutritional standpoint, he's high risk, but who else is high risk? Could you paint a picture for us?
Right. And high risk, I think, helps us cast a wider net. You could make a case, and I could actually, I've made this case before from a wellness point of view, that because there are so many different things that can cause fatty liver disease, that doing something called a fibroscan, it could be part of a wellness screening test. But casting a net, who do we want to look at who's high risk? So somebody that's overweight, somebody that when we check there's something called metabolic syndrome. And with metabolic syndrome, you have, it depends on waist circumference, a larger waist circumference. You're looking at when you look at the blood tests, you look at high triglycerides, you look at low good cholesterol, you look at higher blood pressure. Those people are definitely higher risk. Another high risk class is going to be the people that just in general have insulin resistance. And I'll tell you the scary thing about the insulin, what's happening now in society. But insulin resistance, when you take in a certain amount of carbohydrates, your body is supposed to be able to process it. But if you're taking in way more than the body can handle, your pancreas starts to overwork, making a lot of what we call insulin. And insulin is the hormone that can drive sugar to different areas. Like it can drive sugar into fat, drive sugar into the brain. And what can happen is that because overstimulating that insulin creates something called insulin resistance. And with insulin resistance, now the insulin doesn't work as well. And that's actually, for most people, one of the main driving things for fatty liver disease, when they get that insulin resistance. So I'll tell you, so anybody with insulin resistance, I would want to check. But let me tell you, the scary thing they looked at young male adults that were not overweight, and they checked what's called an insulin resistance score, because you don't just check insulin. There's something called you want to look at an insulin, a C-peptide, your glucose, and then there's a calculation. And what they found is almost half of those men, normal weight, had insulin resistance, which means half of those normal weight young men would be at risk for fatty liver disease.
Absolutely, absolutely. So you don't necessarily need to have high blood pressure yet. You don't necessarily need to have high cholesterol, high triglycerides yet. Your waist circumference may be borderline. You may still look good, right? But asking your doctor to check for insulin resistance, and it's a simple calculation. This test is offered at Standard, Quest, and LabCorp. It's offered at it's baseline insulin, it's glucose, it's C-peptide. There is a test that's actually offered through Quest that's covered through your insurance that you can ask your doctor to order, because I feel like a lot of general practitioners are not ordering this test enough, right? I think it should be ordered on every single patient. And another thing is, you don't necessarily want to wait until your patient is 30. We are seeing insulin resistance in very young patients, right? 20s, we are seeing it in pediatric patients as well. So this is something that should be proactively checked, right, on a regular basis. What are some clues that your patient may have insulin resistance? There's certain categories of patients that are higher risk for insulin resistance, right, Doc?
Yeah, so there's physical exam clues, like you mentioned, that the waist circumference could be one of them. Another clue, there's something that sometimes people grow these skin tags. The skin tags, they're kind of like it's like a little mole that's hanging on a stalk. That actually is a sign of insulin resistance. There's something called acanthosis nigrans, which is which is where they have these kind of darker patches on their skin, and really talking to them about what they're eating. If they're eating lots of processed foods, that's a higher chance of them having that insulin resistance. And I'm glad that you mentioned that most aren't going to, like, most doctors don't look at it, but they really should be looking at the insulin resistance. And this is what, to us, I guess we're functional medicine, so we're checking it all the time. But to the conventional provider, that's not how they are trained. This is how I was talking to Dr. Walls. She interviewed me for her next autoimmune summit yesterday, actually. And what we were talking about is that you start getting insulin resistance. When insulin resistance happens, it starts throwing off and damaging the body. Right?
Yes.
Then eventually you can't keep up, and then the sugar can go up in some people. It depends on their genetics. Some people go to fatty liver only, some people and heart disease, and then some people they just can't keep up, and then their sugar level goes up. And then we look at that marker, that A1C. And that A1C, they don't even say anything till it's about 5.7, and they say, "Oh, you're pre-diabetic, just be careful."
Right.
Really, they don't make a big deal about it. And then by the time that they get to that, by the time that it's 6.5, now we got to pay attention and maybe give you medicines. And the reality is that you've had 10 years or 20 years to get your patient healthy, and you've been watching this just slowly happen. And as you're doing your screening, your basic screening tests and whatnot, we as primary care doctors and all physicians, we have a responsibility to prevent the problem and not just watch them. And then once they fall down and break their leg, hold on, don't break your leg in the first place.
Absolutely, absolutely. So going back to this is a spectrum of disease, right? And we can catch it really early, where we're detecting insulin resistance because we're checking it regularly for our patients, at least once or twice a year, right? Based on how the patient is doing in terms of nutrition and lifestyle and other medications that may affect insulin balance as well. And then the end of the spectrum is diabetes, right? Where now we are committed to we are committed to putting you on a GLP-1 because that's all we have to offer. But that
Right.
endpoint is something we want to avoid as primary care preventative physicians, right?
Right.
And the liver disease, the elevated liver enzymes is somewhere at the beginning, it's, kind of early on. It's something you can catch pretty early and something you can start. It's like a red flag that, hey,
Yeah.
let me pay attention. I've got another clue here. But let's talk about one more thing. I really wanted to focus on why sometimes physicians, general physicians, may feel the need to refer a patient to a hepatologist. Why do they feel like, oh, I have to send this patient to a GI or liver doctor? What's the gap there?
I think it's that they just don't know what to do, and they
Mhm,
kind of know gastroenterologists or hepatologists. So that's the gastroenterologists that specialize in the liver. They may know a little bit more. So let me cover myself and refer.
mhm,
Um, and then there's the question of when should you refer, which I think we should really address. I wanted to mention something else though. You meant the liver enzymes. There are a couple of things. So the main liver enzymes we look at is ALT and AST. Those are the two main ones that you check in a rate. We call it a CMP or cardiometabolic panel, and they see the ALT and AST and they see it elevated. So there's two pearls there that I think everybody needs to know. The first pearl is that the numbers that they use on the lab are not optimal. So they've done large population studies, and what they found is that for men, ALT is one of the main liver function enzyme tests that we look at. For men, it should be less than 35. The lab says over 40, up to 40 something is okay. And
yes.
for women, it should be less than 25. So you may have gotten your blood work. Your doctor may have said, or your practitioner may have said, oh, based on this blood work, your liver enzymes are fine. And they're not. There's an inflammation that's happening. And then the second thing is that you have people that it all has to do with their capabilities and genetics. And those people, their liver enzymes look fine. They're normal. They're consistently normal, yet they have fatty liver, and the fatty liver is getting worse and worse and worse and worse. And it can lead to eventually cirrhosis and cancer if we don't deal with it. And that's why it's more than just looking at the liver enzyme. So just for the audience to kind of not, because I don't want them to look at their test and say, oh,
No,
liver's
no,
okay.
that is really important because when I see patients come to me, I see a category of patients who have stone cold normal liver enzymes, right? But the fatty liver was detected maybe on an ultrasound, or maybe a
Yep.
proactive physician had done a fibroscan and we're looking at that. And
Yeah.
then I also see patients who've had mildly elevated liver enzymes for many years, maybe a decade, noted by their primary care physician, but nothing was ever done. And for some reason, it spiked, right? It spiked a little bit, and they felt that triggered to, well, let's go to a GI doctor, a liver doctor, and let's see what's going on. So I want
Right.
patients to also be proactive about your care. When you get these numbers and they say everything is normal, think about, well, has it always been normal? Is there anything spiking red? And I think it's important to remember what Dr. Elyaman said, because sometimes that ALT at 40 is actually much higher than it should be. It's on that high end. So you kind of have to pay attention. But the other question I always get from patients, doc, so let's go back to that, your patient who comes in and he says, well, is this severe? Is it serious? How do I know if it's serious? What's the next step?
All right. So you get a fibroscan if you can. So there's a lot of centers that will do a fibroscan for free because they're studying different drugs like GLP-1s to see what drug can I give for people that have liver disease. Now, I think what we have to do is go back and see what are the stages of fatty liver disease and what are the processes.
Let's dial a little bit back. What is a fibroscan? Because that's you're talking
Okay.
our language, but maybe people don't
Perfect.
know.
So let me weave in the fibroscan test to that as well. Liver starts, your liver can start accumulating fat. You also can start getting inflammation and what we call rusting or oxidative stress happening in the liver. As that process is happening, eventually the liver can start to damage, and that damage is called fibrosis or hardening. When it's in that fat inflammation stage, it's easier to reverse. the more that the liver starts turning to fibrosis or hardening, the harder it is going to be to reverse. The more you're going to have to deal with the healthy cells and try to get those healthy. The FibroScan is a test using ultrasound technology, but it's very specific. What it does is it's able to give us two numbers. It gives us a CAP score, CAP, and that CAP score tells us what % fat is in the liver. Knowing that the liver is supposed to be less than 5% fat, you see a CAP score and the range is 30 to 40%, you know, okay, that gives me a number. Not only does it give me a number to tell me how bad it is and to stage it, but it also gives me something that I could work on to reverse it. Because you know how many people go to the doctor's office and they see that they have fatty liver disease, and then next year they do an ultrasound and say you still have fatty liver disease, or they never check it again. Well, hold on a second. Why, if we have a score or a number, I could actually recheck it after I've done some sort of intervention, and I could see that the liver is a little bit better. Not just an all or none thing. No, wait a minute. You went from a stage 3 to a stage 2 to a stage 1. So there's the fat part. The second part is when they really need to get the referral, where the primary care wants to refer to a gastroenterologist, is the fibrosis score.
Absolutely.
And that's how the hardening of the liver. And you go F1, 2, 3, 4, which is cirrhosis. And cirrhosis is, that's when most of it is kind of fibrosed and the liver is just really not working well. So the nice thing about that is it's going to be able to check the CAP score and the fibrosis score, how much hardening and how much fat is in there. And based on that, we can put them on a treatment plan. And if they have a lot of fibrosis, that's when you want to
refer to us, refer to
that's
GI.
when we want to refer to a hepatologist. And if they're worth their weight in Bitcoin, the primary care provider will not drop the ball and say, go to the hepatologist. No, the hepatologist will see if they need to be on a study or whatnot. And then they can dig deep and they can say, do they have iron overload? Do they have, they dig and try to find out, are there underlying things that are going on? Are there, do they have a high GGT? Maybe put them on certain supplements, maybe put them on certain, so their job is never done. Their job is never done. But you get that hepatologist on board because it can, if it turns to cirrhosis, then those people are high risk for other things.
Absolutely. And I think that it's important when you're assessing severity as a primary care doctor, internist, or whatever, that you are looking at different modalities, right? Because sometimes the test is not super accurate for that middle zone, you know, that gray zone of patients who are F2 to F3. So adding on additional tests, right? And so very often in my practice, I'll add on something like the ELF test, which is just the blood work, which helps you also, you know, really be able to make a decision as to where the fibrosis score really is. So this is also another test that is available through Quest and other labs, right, that you can order, that's covered through insurance. So that's really important.
Yeah, and there's one more. Let me just add to that. So the ELF test is something we check, because the ELF test tells us how much hardening the liver, so for those, especially for those people that don't have access to a FibroScan, that ELF test, when they start seeing that high, refer to the gastroenterologist. But the other thing that they can do is you can, especially with Quest Labs, you can do a CMP with what's called a FIB-4. And a FIB-4 is a calculation that is going to look at your liver enzymes and look at your platelets. And based on that, it's going to give you a number, and it's going to say, are you at higher risk for having fibrosis or hardening? And the reason for that is that the liver makes a hormone called thrombopoietin, which is responsible for making platelets, the little sticky looking things that help us clot when we have a cut. And so when those platelets start to go down, even though the ALT will look normal, the AST will look normal, and the platelets will look normal, when they do that calculation, they'll see in relation to each other, is that off? And if that FIB-4 score is up without even doing an ELF, those people, you need to kind of dig a little deeper. Those people, I would get a FibroScan, or I'll do an ELF, and I'll try to see what's happening. And the biggest mistake they make is they say, oh, you don't have fibrosis, you're fine, see you in 6 months, see you in a year. I'm like, no, we need to reverse this. You still have fatty liver disease. We need to reverse it so you don't have to go to a gastroenterologist.
Well, you don't have to have fibrosis. I mean, that's the whole goal. We don't want to wait till things evolve, right? So a lot of these tests are available, guys, right? FibroScan is available in most large institutions, right? A lot of smaller ones are now offering it, and you can actually get the machine in your office. I actually think primary care doctors, because of the number of diabetes, metabolic syndrome, insulin resistance they see, I would scan pretty much everybody. Initially,
Absolutely.
initial baseline scan. It's a great test that we now have. It's been evolving over years. I think it's getting better. I think it's a great baseline test and something objective for the patient to see what's my severity, where am I at, and how can I reverse this. I think the FIB test, is a simple calculation you can do even with a CMP. You don't need to order any special test. It's just a score. You can do it online. And I think it's always important just to rule out hepatitis, right? If there are elevated liver enzymes, that's something the primary care doctor can do, rule out hepatitis. The ELF score, I think, provides a lot of information too. So those are some baseline tests that can be done by primary care doctors to kind of see what's the next step. Do I need to refer this patient, or do I just need to be aggressive? So let's talk about reversal. Where would you start? What interventions are most impactful for your patients?
So I'm going to look at the most common causes, and usually the two most common causes are going to be a high uric acid and insulin resistance. And that's kind of where you start. So from an insulin resistance point of view, that insulin resistance score is elevated. You work on a Mediterranean food plan. The data shows you could work on, because people go on keto and people go on low carb and people go on
intermittent fasting and keto,
intermittent fasting, and all those things work. Actually, all those things are great. I'm not, some people will hear me say Mediterranean and then say, oh, he's against keto. No, not against keto. I'm against like all or noning anything, right? So we do see people, they go on a keto food plan, and there's data, they go on a keto plan and that their fatty liver gets better. But the test, the MACDaddy, the test that shows that independent of weight loss, meaning you could eat this food plan and not lose a pound, independent of weight loss, the Mediterranean food plan is by far what looks in research to be the best for reversing fatty liver. But what's the best for your patient? The one that they're going to be the most compliant with, right? The one that works and that's going to be most compliant with. So you get them on a metabolic food plan. The second, I mentioned, they kind of go hand in hand. If you look at sugar is a combination between, it has sucrose, which is glucose plus fructose. Fructose you get in juices. You also get fructose in any sugar, right? So the fructose, if you have too much fructose, it pushes into becoming uric acid. And the lab is a little off with this. You really want your uric acid level. Uric acid isn't just for gout. Uric acid is for metabolic as well. So if you want it less than 5.5, and then you want to get your insulin resistance score to normal. So those are the two markers you're looking at. And cutting down sugar, Mediterranean food plan, and exercise are a great step. Then you can start going, you can kind of dig a little bit and if their liver enzymes are up, I'm going to give them things to help with liver enzymes. Like there's a supplement called N-acetylcysteine that increases the risk, your glutathione or your rust busting ability. I'm going to give them things like milk thistle. I'm going to give them things like, for insulin resistance, I'll give them things like berberine. For high uric acid, I can give them things like green tea extract and dark cherry extract and quercetin, and all those things kind of help with the liver anyway. And then if it, and you kind of start, and then sometimes I'll add, there is a MACDaddy supplement that I've found works amazing for fatty liver called phosphatidylcholine, and found in eggs. Choline is found in eggs, but phosphatidylcholine, and I see amazing results with the fatty liver getting better with that. And then, I mean, there's so many. You kind of start, and then you watch, and then you look at tests, and you look at numbers. If they have iron overload, sometimes they're giving blood to kind of get that extra iron out. But it's really a personalized approach. But I think if you start with getting your insulin resistance score and your uric acid numbers down, I think that's the first place to really start.
I love the fact that you said that, because it really is about nutrition first, lifestyle. So following that Mediterranean diet and just, introducing it progressively as to what you can do, removing things away, right? Removing the things that you should not be eating, incorporating exercise. When it comes to supplements, I want to take a minute. I want to stop for a minute here. You know, a lot of you guys will hear milk thistle, quercetin, this, and you'll go online on Amazon and buy a bunch of things that has these name brands in it and say, oh, this is what I'm taking from my liver. You've heard Dr. Elyaman and his experience. He's a board certified pediatrician, family medicine doctor, med peds, integrative medicine, anti-aging, functional medicine. We have studied this. We know what works. We know what can work for certain patients, what won't work for others. We know the doses we need to use. We know when to repeat liver enzymes to make sure that it's not causing any harm on the liver. So it's not a melting pot of a bunch of supplements that you just take to help your liver. You have to work with an experienced provider like myself or Dr. Elyaman to help guide you as to what to take and when to take it. I want to include in supplements as well, vitamin D, extremely important for the liver, extremely important. Vitamin E, extremely important. And omega also plays a role as well, right? Yeah. So it's kind of working with the right person, the right physician to help personalize that supplement regimen for you. That's just as important. Okay.
So Dr. V, I kind of want to, because even though you're telling them not to do that, some people just can't help it. I might be one of those people that just can't help it. I want to try every supplement possible. But you mentioned the vitamin E, and I just want everybody to know vitamin E is not the regular vitamin E that you get from the store is D-alpha tocopherol. It actually there's studies that show increased mortality, increased death. That is not what you want to be on. The only benefit is it's cheap. There's 8 forms of vitamin E: alpha, beta, delta, gamma tocopherol, alpha, beta, delta, gamma tocotrienol. All 8 of them are what a natural vitamin E is. And the study that showed improvement in fatty liver was looking at treating them with all 8 of them. But if you give one of them, it may actually be blocking the other 7 from getting in, and you may be causing a vitamin E deficiency. And that's where you really want to deal with someone that knows what they're doing.
See what I'm talking about, guys? Dr. Elyaman knows what he's talking about. So if you just go and buy some random stuff, you don't have the data, you don't have the know-how, you don't have the knowledge. Work with physicians who can actually explain it to you, understand the science behind it, and make sure that it's effective. You're not wasting money. You're just not pumping money down the drain. So I think that's really, really important. How do you monitor progress? So you have a patient doing great on the Mediterranean diet, exercising, taking the right supplements, not yet ready for a prescription medication, not there yet, right? So how do you monitor? How often do you see this patient and what do you do next?
So you look at blood and you look at their fibroscans if you can. And you look at the ultrasounds. My ultimate goal is I want to do a regular ultrasound and I want it to be normal, and I want a fibroscan to look normal. That's when we go into kind of the maintenance phase. So those are the tests you can do. Sometimes I will say, let's get this thing going. I'll do a fibroscan in 3 months. Sometimes I'll do it in 6 months. I'll do an ultrasound every year, because if you have fatty liver, you have a higher chance of getting liver cancer. It's not a huge chance, but there's a higher chance. So I want to make sure nothing is popping up ugly in that. And it creates more of that awareness that I have to take care of my liver. I will work on, I will then look at certain markers. And if those markers are high and we know they contribute to fatty liver, I'm going to want to decrease them. So one of the things I'm going to want to look at is going to be the insulin resistance score and their sugar, their A1C level. And I'm going to want to watch that go down. I'm going to want to look at either uric acid. I'm going to want to get that down to a normal range. I'm going to want to look at if they have iron overload or they have elevated ferritin, iron because of the inflammation that's happening. I want to watch that go down. If they do have inflammation, a high sensitivity CRP, I'm going to want to watch that go down. If they have a high homocysteine, maybe they're drinking a lot of alcohol, or they have something called the MTHFR gene mutation where they can't convert folate to methylfolate. That homocysteine is a toxic. It's a toxin for the liver. I'm going to want to watch that go down. And if it really depends. If I feel like if their GGT is very high, I'm going to want to watch that GGT it's a marker that tells us that we're using a lot of antioxidant glutathione. I'll usually give them something like CoQ10, and I'm going to want to watch that go down, and I'm going to want to watch these based on what markers off. And then finally, I'm going to want to optimize their thyroid levels. The only drug that's right now FDA approved for fatty liver is resmetirom, which is a type of a thyroid. It's called a beta 2 agonist for the thyroid, and this basically what it does, or a beta agonist of the thyroid, and what it does is that it gives you they're giving you a thyroid medicine that doesn't affect the heart as much, but we in functional medicine optimize their thyroid labs, and we get and by optimizing the thyroid labs, that also reverses fatty liver. So that's where it gets to be. It's not just I take this supplement and see what happens. That's where you figure out what is actually going on with you in the first place, and then you monitor and you track the things that are off until they go back to they're fine and healthy, and then live happily ever after.
Okay. So I do think I don't think I would check a FibroScan at 3 months. I think it's it's kind of soon, unless the patient is really insisting on looking for results. And sometimes patients just want some objective data. I usually will check at 6 months. And the second thing I want to highlight in terms of the risk of cancer, liver cancer and fatty liver, a few studies have come out that have actually shown fatty liver behaves very similarly to Hep B, where you don't necessarily need to have cirrhosis to have liver disease. We are sometimes seeing liver tumors in non-cirrhotic livers. So the inflammation that's driving this, the insulin resistance and inflammation that's driving this is really what's going to cause that liver tumor. So I do check an ultrasound at every 6 months, at least once a year. So I do that combined ultrasound FibroScan testing, which is really helpful. Yeah. We have seen some de novo liver cancer in a non-cirrhotic fatty liver patient, which I think is something we may see more of.
So we have the benefit because we have the research centers next to us, and they'll check a FibroScan anytime we ask them to. What we'll see is
too, right?
What I've found happen, you do a FibroScan in 6 months, and they may actually in 3 months then start doing what they're supposed to do. And because I can see the CAP score, I'm not as concerned about fibrosis. I'm thinking about the CAP score. If I show them that their liver goes from an S2 to an S1 or an S3 to S1 in 3 months, it gives them that motivation. And it really depends on their level. I think that's where it depends on it. So guideline wise, yeah, 6 months. But if you're pushing it more into the wellness space, because I know for a fact, I've seen people go from S3 to no more fatty liver in 3 months, but they hit it hard. They hit it hard.
They hit it hard.
Yeah.
They've lost a significant amount of weight. They brought exercise in. That's fantastic. So this has been an amazing conversation. What do you think is the evolution of fatty liver management? Like, how are we going to see this evolve? I don't know. I'm having a hard time getting Rezdiffra approved, prior authorization approved for a lot of my patients. I'm seeing it denied first time around, and I'm having to appeal and do additional testing. I don't know how long this medication is going to last for. Again, this is a default medication, right? This is because we've waited too long. We haven't done the prevention. We haven't tried to reverse, and now we're at this point, right? Yeah. But where do you see things evolving in terms of the natural course of fatty liver, the history of fatty liver today?
I think early screening and a set biomarker panel, and then individualized lifestyle supplement, and then maybe medication as the last case. Okay. I do think that the medication like semaglutide or Manjaro, like tirzepatide, I do think that they're probably going to get approved very soon for reversal of fatty liver disease. I don't know what the long-term implications are. My hope and dream is that people will get on with a functional medicine approach and start actually digging deep and figuring out what is causing it in the first place. You mentioned supplements, like the patients run and take supplements. I mean, how many times do we see patients get poor quality supplements that have toxins actually in them? And then that is causing that's causing their liver to get bad. And you know what? You need to stop these supplements because the FDA doesn't regulate supplements the way that they regulate medication. They leave it up to the manufacturer to be responsible. And so many times you have toxins that are in those supplements themselves.
Absolutely. Absolutely. And I think patients have to be aware of this, right? And a lot of things we see on social media and TikTok and try this and try that. I think you really have to have make an informed decision and talk to someone knowledgeable who can guide you in that sense. So it sounds like prevention is key, and early prevention is the goal when it comes to fatty liver in terms of preventing it from even happening, identifying it quickly. And I want to empower our primary care physicians, our pediatricians, our internists, our family medicine docs. The workup is there. Start early. Identify this early. The tests are available. FibroScan is available. Learn about it a little bit more. Tackle it. And refer the patients who absolutely need referral, meaning we're concerned that they have complications. They have bridging fibrosis, which is F3. We're concerned that they have portal hypertension, ascites, varices, cirrhosis. These are patients that we want to monitor very closely. These are patients who we do not give Rezdiffra to. That's an absolute contraindication because they may decompensate. And refer the patients who you think there may be more going on than just fatty liver, right? Are we dealing with a hemochromatosis patient? Is this an alpha-1 antitrypsin? Is this an autoimmune hepatitis related to someone who may already have an existing autoimmune condition? Those are the patients that I feel we can help. But for the most part, I think it's important to empower our primary care physicians, take care of these patients early. The data is out there. Dr. Elyaman has been very, very generous in explaining his protocols, his methodology, and the success rate. Tell us a little bit about your success rate. What are we seeing what are you seeing in your patients?
It really depends on their level of
Commitment.
encouragement. Yes, and commitment. And that's the thing. We meet people where they're at. So we have people that go from fatty liver to no fatty liver at all. We have people that maybe go from a higher amount of fat to a lesser fat, and we're on a journey. I mean, it's so just depending on commitment. But I can tell you, people that go on the food plan, that exercise, that take their individualized supplements, we see this thing reversing.
Fantastic. Doc, where can patients find you? You're not just the fatty liver doc. You do many things. You are an expert.
I hang out on TikTok.
You hang out on TikTok. You also hang out on Instagram.
And Instagram. They need to. We've done our collabs, and people are liking it. But the problem is that like my friends will be like, "Oh, I love me some Dr. V," and I'm like, "What am I, chopped liver?" With the collaboration.
Here we go with the narcissistic stuff again, right? No, but seriously,
reverse narcissism.
No, seriously. If patients are watching this, right? Are you accepting new patients to your practice? Are you seeing patients just who reside within Florida, or are you extending beyond? Do you do virtual visits? Tell us a little bit more about how they can reach you.
Yeah, we see patients in Marion County or in Ocala, and I personally I'm directing the practice. I don't see new patients myself, but I have a team of health coaches and physicians and nurse practitioners and PAs that can help work with people that have fatty liver. And I do encourage people to go to there's certain people. I think do you do consults like in your state?
Yes.
What's okay?
Yes, I do in the state of
within
Texas.
Your state.
Now also extending a little bit outside our state as well.
Yeah. So we're kind of so my main focus is my community, and then empowering physicians, because you and I both teach physicians and other healthcare practitioners, really extending to physicians for that awareness, because it's really going to take a village. Like it's going to take, we really want to change the mindset. We don't want to be like that secret that people just have to come to us. Unfortunately, we kind of are, except we're getting the information out there. We really want this to be the way that medicine is practiced.
Fantastic. No, that's very true. I think that's the way we can make this impact not just our communities, but globally as well. I think that's really important. So he basically wants y'all to follow him on social media. So I will put the links up there. That's where you'll get most information. He provides a lot of amazing educational resources on his platforms. So I'll post that in the comments so you guys can all follow Dr. Yousef Elyaman on TikTok. Thank you so much for being with us today, Doc. It's been a pleasure having this conversation, and I'm sure that it will be impactful to many patients as well as providers watching this episode.
My pleasure. Thank you.
All right. Bye.
Bye-bye.